Good afternoon, good evening, everybody. Welcome to the third webinar session, which has been organized by Ministry of Health and World Health Organization. I would introduce Georgina Bonnet, who's our health financing expert in World Health Organization, representing multiple countries, and she's based in Kenya. A very wonderful person. Georgina, karibu.
Thank you, dear. Welcome everybody to this webinar session. Just a reminder that this is one of the various webinar sessions that we are organizing on advancing universal health coverage, focusing on health financing reforms. We have gone through the experience of Kenya, explaining in detail the reform. We have also seen in the previous one how other countries, including Kenya, are trying to engage the informal sector. And this one is going to talk about the proxy means testing as the target setting mechanism. So welcome everybody. Now we will have different speakers. We will hear Dr. Shana Holler from the International Labour Organization. She works as a technical officer for social health protection for refugees and host communities. She covers Egypt, Ethiopia, Kenya, Sudan, and Uganda. We will also hear Kenya, what we are doing in proxy means testing design and how it is implementing. We will listen to Pius. Dr. Pius Nganga is a senior statistician and economist at the Kenyan National Bureau of Statistics with extensive experience in poverty and inequality analysis and social protection. He will present together with Dr. Stephen Kaboro. He is a health economist with extensive experience in the private and public sector, and also is the technical lead involved in designing and implementing the means testing for the Social Health Authority in Kenya. We will also have the opportunity to hear our speakers explaining the experience in their countries. We're having a Colombia experience through Dr. Eduardo Alvarado. He's a surgeon and also a former vice minister of the Ministry of Health in Colombia, and also former vice president of the Social Health Insurance in Colombia. He also does consultancies. And we will be delighted to listen to the experience of Colombia. Unfortunately, there's connectivity problems for our colleagues in the Philippines. So let's see if they will manage to connect a little bit later, but we will expect the contributions from Dr. Lemuel Untalan, which is the Vice President and member of the management group at the Philippine Health Insurance Corporation. So thank you very much to all of you. Also, Dr. Valeria McCory is going to be supporting the moderation. And thank you very much. The floor is yours, Amina. Back to you, Amina.
Thank you very much, Georgina. With no further ado, Shana, welcome to the platform. I believe Nelson would share the screens for you. Just as a reminder, kindly learn to turn on the translation part of the webinar. Today we are having an international webinar, so our speaker would speak in Spanish, so it would be important you turn on the transcription so that it can be in English. You can be able to understand it with the subtitles. Thank you. Over to you.
Okay, good afternoon, colleagues. I hope you can hear me well and you can see me as well. In case I break off, I apologize. I'll try my best to keep the internet connection going. So today I'll just quickly give you an introduction from the ILO side on proxy means test and how it's used in social protection, social health protection schemes with a few country examples. So I hope you can see the presentation. In case you can't, please let me know. Oh, there we go. Okay, so proxy means test and what it's used for. So usually a proxy means test is really used to identify the poor. In our case, it's a tool aiming to estimate household consumption based on observable characteristics such as the household composition, housing quality, asset ownership, so how does somebody live, which assets do they own, education, employment, and health indicators. But it doesn't actually assess income. It can't, and it's very rarely used for contribution determination. So it's quite an interesting country example that we have in Kenya. It is quite often used in non-contributory or poverty-targeted social protection schemes. And even in Kenya, and I'll get to that later, it's also used for that. Why is it considered by governments? Because we are talking about a country with a very high informal economy, and this is shared trait of many countries in the region. So high informal economy also means that we have a highly heterogeneous groups with different incomes in different sectors. And it's very difficult to know what these people actually earn or what a household actually earns. So in our case, the PMT is used as a tool to try to assess household consumption using proxies meaning observable characteristics. And that is difficult, and it's also prone to errors. So for proxy means testing, issues that needs to be considered. So what we from the ILO standards always say is contributions for social health insurance should be based on your real ability to pay, right? So countries introduce different measures to make that happen. So either they introduce full or partial subsidies for different groups to make it more affordable. And they also often adapt payment intervals to match income cycles for informal workers. So we know an agricultural worker might harvest twice a year, 3 times a year, and then he or she is able to pay, and not maybe on a monthly basis. So these kind of payment schedules are taken into consideration. I think the Philippines will talk about that if they manage to join us. Then PMTs are prone to exclusion errors, meaning that generally poor households are wrongly classified as non-poor and thus denied benefits, or in our case, maybe then the subsidies. So the risk is high with PMT tools because there's imperfect information. There's measurement errors, there's maybe wrongly set indicators, and the dynamic nature of poverty, and I'll get to that later. So, which is interesting is I was aware, for example, that there are exclusion errors, but it's not small errors that we're talking about. So we've just had a study done in the occupied Palestinian territories before the war began. And with an improved PMT, so they were overhauling their PMT tool, they managed to go down to an exclusion rate of only 35% in their design, while other countries like Myanmar report exclusion errors of up to 90% of the population for their hospital equity funds. So we're really talking about quite substantial exclusion errors. Then we also, of course, see inclusion errors. They're more rare than the exclusion errors, but it means that a household that is actually not considered poor objectively would be classified as poor by the PMT and would receive subsidies. So just to say that targeting of poor households is quite expensive, even for social assistance, and prone to exclusion errors, as I said. So these vulnerability criteria also need to be communicated so that people understand them. And what we've seen in some countries like Cambodia is that they have post-identification system, meaning that if the PMT has either wrongly classified you or you have fallen into poverty in the meantime. So let's say in Cambodia, the PMT is done by community workers and it's done every 3 years. I mean, your household is going to be covered every 3 years because 1/3 of the country is done every year. So that means within 3 years, a lot of people might fall into poverty or lift themselves out of poverty, and this is then not covered. So you need like a post-identification system, ideally, to counteract these exclusion errors that happen over time. Then, as I said, it's quite expensive. So even if and even more so if it's community-based. So the question that we also asked was, if a PMT is not community-based but only online, then how do you verify the information that you get? But if it's community-based, it's of course quite expensive. So the administrative costs for social assistance schemes that use PMT is between 10 and 30%. So for example, in Brasilia, the Bolsa Familia has around 10 to 15% of all the expenditures of the scheme is just going towards the proxy means testing. In Kenya, as far as I know, these costs have been very drastically reduced by the introduction of mobile registration and so on, which really brought it down from 25 to 10% for the social safety nets that we have in Kenya. But it's still a considerable cost. So we have to consider that it will be up to 30% of the actual expenditures. So Kenya already has a PMT tool. It's called the Enhanced Single Registry, which is used in Kenya for the identification of older persons, persons with severe disabilities, orphan children, for the safety nets, so for cash transfers that are paid to the poor. So most countries that have already a PMT tool for social assistance link that to health. And under the previous system with NHIF, this was done. So Kenya used to do Cash Plus, although this wasn't fully rolled out for all cash transfer beneficiaries. Around 50% of all cash transfer beneficiaries were already enrolled free of charge in the NHIF. So just to say that this is quite classic because you have the data, you already know these people are poor or considered in need of assistance. So usually it's linked. If this is now not linked anymore because there is a parallel tool, it is quite important to make sure that these persons that would usually be picked up by the ESR, by the Enhanced Single Registry, that these still continue to also then be picked up by the new PMT as poor or vulnerable. Because of course, for example, if we have orphans, we would still consider them vulnerable, right? So we have to make sure that the PMT still picks these people up. Then, as I said, poverty is very cyclical. We've seen that in Kenya with a few studies, how people are really moving in and out of poverty. I think there's a very good study from UNICEF showcasing that. So in some counties, we have such high poverty rates that basically most people would qualify for subsidies. So that can be even around 80 to 90%. So I'll get to that, which is then called categorical targeting. And then the other thing is social acceptance of a PMT. So you have to see it's quite complex and there's a lack of transparency for the normal population, which can lead to mistrust in the institution. So PMT scores are usually not predictable for the population. If you fill it out online or if somebody comes to assess you, you as the household that is being assessed, you won't understand why you suddenly have to pay a certain amount or why you're exempt from payment. So it's also very important that we either really communicate this very clearly so that the people understand and to make it, with as little exclusion errors as possible so that people don't, it can lead to quite some social unrest, even if one neighbor gets a subsidy and one neighbor does not, but they actually think they have the same income. And so in that sense, categorical targeting with easier identification measures can be easier to understand for the population. And one thing, of course, because I work also for refugees a lot, is to also make sure that this PMT would actually cover the realities of refugees and asylum seekers in camps, because with the new UHC law, they are required to join and supposed to also participate and contribute to the new social health insurance. So it's important that their realities in the camp settings are also reflected in the PMT. So just now going a little bit more to health. So as I said, as per the international social security standards, health benefits should not be proportional to past earnings, and they should not be only provided to people in gainful employment. So we don't want to just see people in the formal sector, right? And I think this is very well captured in the Kenyan constitution. So some countries have really decided to cover the entire population using national health service systems. And we know England as one of those examples, which is non-contributory for the entire population. Then, of course, we have countries that decide to combine contributory, non-contributory schemes like Thailand. So when you're in the formal system and the formal sector, you pay your contributions. And if you're in the informal economy, you are covered through government revenue. Then other countries have decided they wish to use social protection as an incentive for formalization and propose progressive subsidies. So fully for the poorest and then or for specific groups that they have identified, and then partial for others. And I think this is, we usually call it categories. So Rwanda is one of those, Kazakhstan is another. So when we look at PMT use in social health insurance, most countries have used this category of targeting, at least at first, which is then often used linked to social assistance. So for example, we have Vietnam, which started with people that were veterans and people that were poor, people that had severe disabilities, children under 5, pregnant women, and so on. And by adding more and more categories, you cover more and more of the population. If we only use poverty targeting, we often end up in countries where the poorest are covered by health insurance, and then the formal sector and everything in the middle is missing. And so these countries are often struggling to fill this missing middle. And that is a little bit what we've seen with the previous NHIF here too. So then you have, most countries do not use the PMT to establish contributions though for workers in informal economy. They rather use flat rates. And those flat rates can be different for different categories. And again, I think the Philippines would speak to that. And some countries have similarly, like Kenya, recently introduced a percentage of income for workers in informal economy and have quite often then reintroduced flat rates as this percentage then of minimum wage as declared income was not obtainable or reliable. And then most countries who have reached full coverage or almost full coverage in settings with very high informality have usually subsidized either the entire informal economy, I've already mentioned Thailand, or a large percentage like Indonesia. So one of the few countries that have used community-based PMTs for the categorization for social assistance and social health insurance is Rwanda. However, I think one thing that needs to be noticed, so there are only a few categories. It is community-based, but even the highest category, so if you're considered to be in the most richest category with the highest income, is still highly subsidized to ensure affordability. So at the moment, it is around $5 per person in a household per year. So even if you're considered as being the most high earner in Rwanda. So this also shows you how highly subsidized the CBHI in Rwanda is and why they have reached almost 85% coverage in the country. So quickly, recommendations before I close. So one option that I've already mentioned is to consider a flat rate. So 2.75% of minimum wage would be around 440 Kenyan shillings per month. Our studies in Kenya that have worked with the informal economy over the last 4 years have shown an ability and willingness to pay around 300 Kenyan shilling per household per month in the informal economy. Of course, there's more, some that say higher, some say lower, but this was more or less the most agreed upon number actually. So, and then when you're designing policy with really the goal of having universal coverage, then targeting should only be a stepping stone usually. Consider to set the percentage of households that are subsidized as high as possible. As I mentioned, Laos, for example, really struggled for many years with their coverage and now covers 95% of the population. How did they do it? In a very short time, the new national health insurance now covers 75% of the population by default through government revenue. So basically everybody who's in the informal economy, similar to Thailand. The option of using categories, I've mentioned that. You have that option, especially because you have the ESR, but there would also be the option to look a little bit at physical locations. So I've put the map here on the right, and we see that there are certain counties that struggle particularly with incredibly high poverty rates. So one can ask if those counties should be covered completely by default, but that's one of the categories that you can set or not. Definitely categorical targeting is more intuitive for the population. So if the PMT is used as it currently is, then the formula really needs to be verified continuously, and households need a mechanism for grievance and to re-evaluate their poverty status, both at the first assessment, so if they are not assessed according to their feeling in the right way, and also regularly if any household shocks incurred and they cannot afford the current premium that is set for them. So just to say it in the words of our director, compared to poverty-targeted schemes, universal social protection schemes usually receive more public funding, offer higher value transfers for recipients, enjoy higher quality implementation with fewer people in poverty being excluded. So this is just a nice different take on poverty targeting. Of course, every organization has a little bit of a different take on it. Thank you for your attention. And if there's any questions, please let me know. Thank you.
Thank you for your time and thank you for that comprehensive discussion. It was mind-opening and an eye-opener. We'll have the Q&A afterwards just so that we can be able to manage time better. With us next would be Kaboro. Kaboro, I hope you can take briefly discuss our Kenyan setting. She's given us how it's happening across the world. Break it down. Kaboro, are you with us?
Yes, I am, and I hope I'm audible.
Yeah, Nelson, I hope you can share your screen.
All right, I will.
Thank you, Kaboro. Karibu.
Yes, thank you very much, Amina. Thank you for the presentations that you have had. So I will give a small overview about the Kenyan PMT and our approach for PMT towards the universal health coverage. This presentation will be present two of us, myself and Pius Nganga, who will be coming in from the National Bureau of Statistics. And just to be clear, we'll be presenting more of how we have approached proximity testing from the universal health coverage point of view in terms of determining the premium payment and not specifically for social assistance targeting. So I'll begin with a small background regarding the Kenyan economy and how it is structured. So we note that Kenya is the middle income economy, which is, however, heavily biased to the non-salaried informal sector. They are the majority employers in Kenya, so they represent around 81% of the population of who are in the labor force, and only 19% or thereabouts of the labor force is employed and with a salary. So when we look at the aggregate contributions on income between the two sectors, we notice that they're not very different. They're not so much different. So you will find that the 19% salaried employees contribute to around 24% of the economy income, in the income section of the economy. And the 81% non-salaried contribute about 76% of income into the economy. So you see they are not matching one-on-one, but they are almost similar. So with that in mind, previously before we did the UHC reforms, we had the National Hospital Insurance Fund, which was the main insurer for Kenya. And with that, the contributions towards that NHIF was composed of two ways. One was banded contributions from salaried workers. So you'll find income groups in those who are salaried being charged different amounts based on the band which they fall in with their income. I would have an income of maybe between less than 6,000, having the entire band having a contribution premium to the NHIF. Then the next would come from 6,000 to around 10,000 shillings. They would also have their own contribution premium for the NHIF. And then for the non-salaried Kenyans, the NHIF usually used to charge a flat rate or 500 Kenya shillings, which is about $4 for everybody in the informal sector. So one thing we noted from this contribution model was, one, for those who are in the formal salaried sector, the contribution mechanism was heavily disadvantaging those who are in lower income groups. So they would contribute between 3% to around 7%, majority of them, to the insurer. And then those who are in high income, they would contribute mostly less. If you are above 100,000 Kenya shillings, which is roughly about $800 per month, your contribution to NHIF will be 2% or lower. So it used to decrease as your income goes up. So we noted that was very inequitable. And number two, that if all the people in the informal sector contributed 500 shillings as a flat rate, it is still further engaged in inequities in that sector. One, because most of the wealthy populations in Kenya, you'll find them in the informal sector in Kenya currently. So if all of them are contributing a flat rate of 500 shillings, it was very inequitable. Number two, these 500 shillings, if you looked at just that segment of the population, they contribute 500 shillings and then they access services. So the payments, the payout ratio was more than 300%. So for every $1 they contributed, they would consume $3. So we found that even with the subsidization from those who are in the formal sector, the NHIF was not breaking even between the two schemes. And you would find very high default rates for hospitals. I think currently the amount of debt as per last year by NHIF owed to facilities was actually more than $200 being carried over a period of 5 years also. So we found that this was actually going to get the National Health Insurance Fund bankrupt. And this bankruptcy was being driven mostly by this informal sector contributing 500 shillings. So when we started the reform journey, we tried to look at how we're going to harmonize those two areas and ensure that we have enough contributions to the new social health insurance scheme, which actually came into being just last year, actually in October last year. And one of the things that was heavily emphasized on was how to ensure there is equity in contributions to the scheme by both the formal sector and the informal sector. Because as you see, in the formal sector, salaried employees have really been complaining that they're carrying the bulk of the economy in terms of health insurance contributions. So we try to do that in two ways. One, the Kenya Health Financing Strategy and Policy that was actually enacted by Parliament in the year 2020, a flat rate was set. So we said we will move from banded contributions to a flat rate proportion of the salary. And this, it has been changing. It started with 6%, went down to 3%, but the final agreed figure for starting was 2.75%, which was, the 2.75% was actually the weighted average of the contributions in the formal sector. So the weighted average, so you find that those who are in the lower income group, they would actually pay less than what they were paying in the NHIF. And those who are in the higher income groups, they will pay a bit more because we didn't have capping. They will pay more to the new social health insurance scheme, but aggregate contribution when totaled at the new scheme, it will be more or less equal to what was being given to the NHIF. And then the main issue came with the non-salaried. So the key point, and this came from a judicial proclamation that was done for another contribution that was coming into place, which was, I think Kenyans will know it as the housing levy. So the court pronounced that we should not be taxing only the formal sector. So everybody in the economy needs to contribute to any scheme that we're establishing. So with that judicial proclamation, we noted that now for the non-salaried, they needed to also have the same rate of 2.75 of their income to be contributed. And we also were able to have a discussion of what we mean by income, especially for the informal sector. But we said as health we leave that to regulations that are done by the National Treasury and the Central Bank through the Finance Act and Treasury regulations. So that those will define what an income is. And then now I'm going now straight now to the non-salary, because I think that's where the issue mainly was for us. And we noted that there are few challenges that we experience with the non-salaried. One, the informal sector rarely keep books of account. There are very few informal sector groups that will keep books of accounts. Number two is that they have irregular income. So within the year, there will be issues where they are, for example, they're harvesting, they will have an increase in their income, but when maybe they're planting, there will be no income. So that became an issue. And number three, an issue which we tried to explore was the issue of self-declaration of income. So we also noted that that would not be very feasible in Kenya, since one, there is high rate of under declaration, and also number two, even if you ask these informal sector groups to actually declare how much income they get, sometimes it's very difficult for them to enumerate because of the irregularity of income and lack of the books of account. And also we noted that it's also very hard for them actually to differentiate what an income is, what a profit is. It's very difficult when you're in the informal sector. And with that, we explored and tried to see how best we can form a solutions to the informal sector. And a few things that we actually agreed on is that one, the informal sector need to pay premium that is commensurate to their income and not a flat rate. So if we were to go to a flat rate, I think most likely we would have been guided by the previous experience. Not we know as it has been pointed out, the willingness to pay in Kenya is around between 300 to 600 Kenya shillings. That's how much Kenyans would be willing to pay. And that does not mean that's how much they are able to pay. So we need to move from willingness to pay to ability to pay. So in case we have a flat rate and we ensure that the scheme does not collapse, we would most likely have almost tripled the income. I think the calculations were around from 500 shillings to around 1,200 shillings per month, which was not feasible at the moment. It will still enhance more inequities. So the second thing that we noted is that we needed to have a way to estimate the income of this informal sector. Irrespective of how it is, at least we needed to give it a try. And after a lot of discussions between the main groups within the region, we brought together teams from the ministry, from the National Bureau of Statistics, that is the main body responsible for statistics in Kenya, and universities in Kenya. And we also brought in regional experts from the region, West Africa and the Eastern African region, mainly through the WHO. World Health Organization actually assisted a lot in bringing together this group of experts and mathematicians together. And what we agreed on was to enhance the existing income estimation tools. So we said we already have estimation tools, especially for welfare subsidy. We already have these tools. So in case we want to start off, we needed to start off from there, at least for the first itinerary before we perfect the way we measure income. We started off from the existing income tools, and then we enhanced them. So Dr. Pius will come in after this slide. I hope you share it. So we go now to the proxy means testing, and I think I won't talk much about this. It has actually been discussed well. So let me just indicate that for our case, we were foreseeing that this proxy means testing, we could adopt it, actually enhance it and use it to establish income levels. And if we have income levels, at least we'd have a way of establishing contributions and health subsidization for the poor. So at least we would have a way of categorizing people into different income groups, irrespective, even when they're in the informal sector. And in the country, we are targeting around 1.2 million households in Kenya, around 81% of the population. And for each income category, once we establish the income, the usual rate or the gazetted rate of 2.75% of income now comes into play, and we will charge it on that. So I will have the Pius Nganga from the National Bureau of Statistics take us through the means testing tool. Pius Nganga, please come in.
Thank you, Stephen. Thank you for the detailed background that you have presented. I think I'm supposed to take over to the proxy means testing. I would request the presenter to kindly move to the next presentation slide. Yeah, we can start from here. So, and okay, don't mind the background noise, if any. I mean, somewhere there is some noise, but I hope I'm audible enough. So here we are looking at the solution for informal sector. As Stephen has said, if you want to determine how much someone should pay and is from an informal sector, then you need to find a way of estimating someone's income so that you can be able to tell them how much they should be contributing. So I think
Apologies.
we are already, yes?
Yeah, just in the interest of time, if we can keep it 5 minutes, thank you.
Sure, I will. We can go to the next slide. So in Kenya, we did some sensitivity analysis on which model should be able to estimate someone's income, and you can go to the next slide. We are talking of the PMT.
Yes, I think I'm having a challenge in presentation. Let me check and then represent again.
Okay, it's okay. So you'll find that we tried to explore the option of the ordinary least squares, and also we also explored the option of the logistic regression. And in this case, we have adopted the two-step logistic regression, whereby from the data set that we are using on the Kenya Integrated Household, Kenya, we used the 2021 Kenya Continuous Household Survey data, which has some data on consumption expenditure, which can be taken as a proxy to income. So the data set had around 16,900 something households, and we applied the two-step logistic regression. So what we did, the first step, we did split the data into two income brackets or three categories. And the first category was for those households whose monthly income is between 0 to 5,000 Kenya shillings. Then the second category was on 5,000 to 10,000. And then the third one was of, the first sorry, you can go back to yeah. So this is the two-step regression equation that we adopted. And so the variables that we are using, the easily identifiable variables, which are sometimes related to the welfare of the households. And these variables basically includes the household and individual characteristic variables. Move to the next slide. So in this slide is where we are explaining the two-step logistic classification model, whereby we have the three categories: the low income, middle income, and the high income households. And then in the next step, we also categorize the households. For those which were in low income categories, we also had I think 4 categories. But in this case, we have 3, that is 0 to 5,000, 5,000 to 10,000, and then 10,000 to 20,000. And then the other one was the second category. So we ensured, for this case, there is some overlap, but we ensured that we do not have overlap in terms of the income brackets. So, the logistic regression, the output is usually the the probabilities. So it would basically means that if you fall into this category, maybe the third category, within the third category, we have 3 brackets, the minimum income. Like for example, if you look at the high income households and you look at the third category, we have 3 income brackets, that is 100,000 to 300,000, 300 to 5,000, and over 500 to 1 million. So basically, we are taking the lower limit as your income, because logistics regulation is not likely to predict the actual income. Next slide. Yeah, so we did some metrics on the performance of this model, and we found that it's able to accurately predict with an accuracy of 75%. And due to the overestimation of the income, that's why we are basing the minimum of each income bracket. So you can see we have an overestimation of 25%, and that's why we decided to take the minimum income of that bracket. Next. Yeah, so I think, Stephen, maybe you can wind up on the yield prediction.
Yes, I can do that maybe in 1 minute, host. So for that, we try to predict how much based on the income levels. We try to estimate how much we can collect from this model, and the total was coming to around 148 billion from both the formal and the informal sector. So that would bring an average contribution per month of around 1,200 shillings, or about $9. And for the last 4 months, we have been able to actually carry out proximity testing with about 3 million households. So I would like to put a caveat that the proximity testing people are doing self-reporting. They're doing either self-reporting or assisted entry in the ground. So what you see there in red is what we had projected to be the income levels for each category group, and the numbers you see there is their contribution premium per month. And then the blue line is what we are actually getting for the around 3 million or so households that have undertaken means testing. So we are getting a lot of heavy badge in the low income households, more than what we are expecting in the general population. And then for those who are in the middle income and high income, we are getting less than what we expected. So that brings us the key challenge. So what you're trying to do now is, it's only 3 months or 4 months since we started. So you want to understand the model, where the challenge is and why you're not getting what you expected from the population. So one, would it be because the population is giving incorrect data because they know the data they provide will determine their contribution level? So is it that they're giving incorrect data? Or number two, is the registration process, because the registration process is being driven in the lower levels by assisted registration, means mainly the community health volunteers. Is it that they are basing the recruitment on only the low income households and they're not moving to high income households? So I think currently that's where we have reached, and that's the outcome we have and the challenges. And with that, I would like to end my presentation, and back to you, Jason.
Thank you. Thank you very much for that. Very, very informative. I like how you ended with the current status in the country. Very informative. So I hope everybody has their transcription. I know I've been asking you and I haven't even been doing it myself, but press your caption and write my speaking language is English. With us next is all the way from, sorry, just give me 1 second. Philippine is next. Hi.
Hi, good evening.
Yeah, I can see your up. I don't know if Dr. Eduardo Alvarados is there from Ministry of Health of Colombia. But Philippine, go ahead. Dr. Lemuel, welcome very much. Thank you very much for giving us your time. We value it, and we are waiting to hear what we can learn from Philippines. Karibu, Kenya.
Okay, I just have to check if my presentation is coming through. Good evening from the Philippines and good afternoon to Kenya. I just have to share my slide. Wait first. Okay, are you seeing my slide?
Yes, thank you.
Okay, thank you very much. Okay, good evening from the Philippines and good afternoon in Kenya, and also to the participants of this webinar. I'm sharing you, this is my presentation during the 8th Global Symposium on Health Systems Research that was conducted last year in Nagasaki, Japan. And I hope some of you have already seen this presentation. Basically, I'm sharing the Philippine experience on how we implement the National Health Insurance Program to get your expectation. I will not go on the technical side of how on the proximins test we're using. PhilHealth, as the administrator of the National Health Insurance Program in the Philippines, is the end user of the activity being conducted by another government agency. This is the Department of Social Welfare and Development. So their agency is tasked to identify who are the poor and where they are. So I'm not going to on that level, on that technical, but on how we use the proximity test being conducted by the Department of Social Welfare and Development. Okay, this is for this year. The National Health Insurance Program in the Philippines has been there since 1995. So we are celebrating our 30th year this year, 2025. It started in February of 1995. It has already underwent 4 revisions of the law in the implementation of the National Health Insurance Program. And currently, the law is also being revisited and being amended. And hopefully, this would be the version 1, 2, 3, 4, version 5 of the how the PhilHealth as the administration of the program being implemented. So the law is currently being amended, and hopefully it would be passed by mid-year on those amendment provisions. So it has already underwent 5 cycles. No? So this chart only shows the line graph shows the projected population of the Philippines, and the bar graph shows the relationship between the contributor. The orange one are the contributing members. These are the employed, the self-employed, and even the migrant workers in this category. When we started the program in way back in 1999, indigents are very small, and through the years it has increased coverage of the poor. I would explain to you next slide on what are the possible what are the reasons, or what has been the legal basis. I would just like to, I think it is unique in the Philippines that the contributions of the poor, the indigents, has been it is legislated, and its fund source is through the sin tax law. So excise tax from tobacco products, alcohol, and even unsweetened beverages are the fund sources for the subsidy for the implementation of the NHIP. Most likely these are for the contributions or the health premiums of the poor and other vulnerable sectors. And then in 2018, there's what we call the PhilSys Act, which is what we call the national ID. So it is only in 2018 where all Filipinos should register and come up with a national ID. And then in 2019, this is the Community-Based Monitoring Systems Act, where the identification of poor was enacted. From now, there's a law that our Philippine Statistics Authority would be the one conducting this census or assessment of all Filipinos if they are poor or not. Right now, it is the function of the Department of Social Welfare and Development. So this is the way in the Philippines we target or enroll the poor and the vulnerable sectors. Way back in 1995, the target, the poor or the indigents, the local government units, whether the city, municipalities, or the provincial, are the ones who identify who the poor are in their locality. They adopted what they call a modified family data survey form. Basically, on the first, it's a two-page form, a survey form. On the first page is mostly on access to basic services. If they have water, they have toilet, if they are what are the material of their house. So those are, and the second page would really more on the family profile, who are the members of family, the age, the sex, and if there are if they are working, and then how much is their family income. And using that tool, we relate, based on their declaration of family income, we match it with the poverty threshold in their locality. If their family income is below the poverty threshold for that locality, then they are considered as eligible for this program. And who pays for the contributions of the indigents, the poor? Since 1995 to 2013, it's a shared contribution between the local government unit and national government unit. So depending on the income class of a local government unit, if their income class is 4 to 6 class, the subsidy would be 90% of the estimated annual premium for that. So 90% for share for the local government, and 90, and it will gradually increase until such time they have reached the first and second, third class income classification. But in 2019, when the law has been revised, amended on the third time, this is RA 10606, the identification of poor is now lodged with national government through the Department of Social Welfare and Development. This is aligned with another program. This is the conditional cash transfer. So they have to identify who would be the beneficiaries. So we adapted what the Department of Social Welfare and Development, the proxy-means test. I think it's a modification of the Colombian model, because way back then, I think the consultant for DSWD came from Colombia, and I think they have some inputs on the proxy-means test. So this is what we call National Household Targeting System for Poverty Reduction. The difference in 2019 on the third amendment of the law is that the national government now pays for the contributions of the poor, the indigents, in 2019. As I have mentioned before, the local government identifies, and then the premium of the poor is shared by the local government and national government. But in 2019, the department, or it is centralized, only the Department of Social Welfare, using the tool, identifies who are the poor and where they are, and then government pays for the contribution of the indigents or the poor, as I presented, funded mostly of the sin tax money. In 2019, this is the fourth amendment of the law. The target beneficiaries has been expanded to include persons with disabilities, senior citizens, and solo parents. And then who identifies, basically the indigents are still being identified by DSWD, but on persons with disability, solo parents, there's a law on that, a Magna Carta for persons with disability, a Magna Carta for solo parents. So there are special laws. The local government units are the ones who identify or assess if a Filipino has a disability or a Filipino is a solo parent. So until now, national government is providing the funds for the premium of these sectors, the indigents and also the vulnerable sectors. I think this is unique to the Philippines. By law, it is one of the reforms in 2019. That's February of 2019 when the Universal Healthcare Act was signed into the law, and following the WHO Cube model, on population coverage, it has been declared by the Philippines that every Filipino shall automatically be included into the National Health Insurance Program. So all Filipinos need only to register with PhilHealth to be assigned a PhilHealth identification number. So that is the task, one of the reforms to ensure population coverage. So all Filipinos are automatically under the program. The second reform is that it is also provided by law that every Filipino shall be granted immediate eligibility and access to preventive, promotive, curative, rehabilitative, and palliative care for medical, dental, mental, and emergency health services. So this is service coverage. And then included in the law that every Filipino shall register with a public or private primary care provider of choice. So we have to not only focus on curative care, but also on preventive and promotive care, that every Filipino shall now be registered to their preferred primary care provider. And then under the law, in 2019, they have two kinds of health services: population-based health services, which shall be financed by national government through our Department of Health and should be provided free of charge at point of service for all Filipinos. That's the population health services. And then the individual-based health services shall be financed primarily through prepayment schemes, such as social health insurance, private health insurance, HMO, health maintenance organization plans, to ensure predictability of health expenditures. So in the WHO Cube, this is the financial coverage. So right now, under the current law of Universal Healthcare Act, there are only two types of program membership. One is called direct contributors. So these are those Filipinos who have the capacity to pay premiums. And if they have the capacity to pay premiums, how they could contribute to the program is depending on their employment status. If they are gainfully employed and are bound by an employer-employee relationship, this is the premium is being shared by the employee and the employer. And if they are self-earning professional practitioners and migrant workers, including their qualified dependents and lifetime, and for the self-earning professionals, they pay wholly on the premium. Right now, our premium has an income floor and an income ceiling. In pesos, that's 10,000 pesos, and that's the income floor. And the income ceiling is 100,000 pesos. So with a premium rate of 5% this year. Okay, and the other type of membership is what they call indirect contributors. This refer to all others not included as direct contributors. So if you do not have the capacity to pay premiums, you are considered indirect contributors. Where their premiums shall be subsidized by the national government, including those who are subsidized as a result of special laws. So the special laws, as I have mentioned, is the Magna Carta for persons of disabilities, Magna Carta for solo parents, Magna Carta for senior citizens and the elderly. So their premium is being subsidized by the national government. Okay, so these are the sample of direct contributors: employees with formal employment, self-earning individuals, professional practitioners, migrant workers or overseas Filipinos, lifetime members. These are members who have already reached the age of retirement and contributed at least 120 months. So if they have already reached that kind of membership, they don't anymore contribute to the program. And also the kasambahay, this is the domestic workers, household workers, and also the also Filipinos who are 21 years above and who have the capacity to pay. And even we have also considered Filipinos living abroad, also those who Filipinos who opt for dual citizenship, and even naturalized Filipinos. For indirect contributors, these are, as I have the listahanan, this is under the National Household Targeting System of the DSWD. So the indigents identified by the DSWD. Under also one of the program of the DSWD is the Pantawid Pamilyang Filipino Program beneficiaries, or the conditional cash transfer beneficiaries. The following are based on special laws. This is the senior citizens who are not currently covered under the program, persons with disability, sangguniang kabataan officials, they are youth officials, and also even those Filipinos who are 21 years old and above without the capacity to pay PBRUM. We have another program. This is what we call point of service financially incapable enrollees. This is an offshoot of those Filipinos who are in a way exclusion error. They are poor, but they are not identified under the listahanan of the DSWD. So these are the challenges basically we face as implementer of the National Health Insurance Program. Turnaround time on the provision of list of beneficiaries is not, because the list of poor came from another department. So we could not insist that we heavily dependent on giving us the list on time or before a fiscal year. And also the problem of availability of the updated list of program beneficiaries from strategic covered partners, because they provide us the list in a time certain deadlines, but most likely the list is very fluid. One concern is the list may contain some people who have already died, so that is already a challenge. And it is through data sharing agreement, one common problem is the common matching key regarding data matching of program beneficiaries. So their list, we have to match with our database, our list, and that is in a way a challenge we're facing as an implementer of the program. And then we have also the challenge of available information and communication technology infrastructure of the originating government agency and the receiving. So there may be some the incompatibilities, or some agencies have invested in ICT, some are not. So some could be transmitted through application programming language, API, some through Excel file, and the worst thing is they have just a printed listing given to us and to encode. So recommendations on moving forward, if you would consider as an implementer, we are proposing for a one tool on the identification of the poor. No, right now there is by law the community-based monitoring system. So that is now we're shifting from the DSWD tool of the National Household Targeting System for poverty reduction to the community-based monitoring system, which is provided by law. Another agency is doing that. So one government agency that lead or oversees the identification of poor. So right now it is a centralized. Before it is through the local government unit. So it is I think efficient and more focused if we could only talk to one agency that you are responsible for identification of poor. And the problem is the interoperability of the sharing of data between and among government agencies involved. And I think if one agency is identifying the poor to whatever methodology, right now is the CBMS, I think the question is, as part of the whole of government, whole of systems approach or nation approach, the list should be shared with other governments agencies who are involved in social protection or social security. So I think that should be the moving forward. But still, even it would be shared, we should ensure data subject data privacy is protected and secured. And it is one also of those things during the health systems research in Nagasaki that a national identification system really helped. PhilHealth is as mandated by law that we have to integrate our processes and even our systems with the national identification system. So we really have to integrate and be interoperable with the national identification system. No? So to in a way to reduce cost in the implementation of various programs. I think that ends my presentation. So thank you very much, and thank you for this opportunity, and good evening and good afternoon to all.
Thank you. Thank you. Good evening to you. Thank you for the wonderful session. We have learned a lot about what is happening in Philippines, and we have also learned that changing of laws is actually quite common, more than we actually think. So without further ado, I can see you can ask Q&A on the Q&A. You can ask your questions there. But in the interest of time, I would love to introduce Dr. Eduardo so that he can be able to give us his overview on what's happening in Colombia, hopefully with a specific focus on proxy means testing. So, Karibu, welcome. Dr. Eduardo, can you hear us? Sorry, let me.
Eduardo, estás en mute.
Eduardo? Yeah, sorry. Bien. Georgina, kindly. He's in. Maybe there's a language barrier.
Muy buenos días en Colombia y muy buenas tardes en Kenia. Muchas gracias por la invitación a participar en este webinar. Voy a compartir la presentación. Para mostrar algunas lecciones aprendidas de la experiencia de Colombia en el avance hacia la cobertura universal en salud y cómo se focalizaron de alguna manera los subsidios para alcanzarla. Quisiera primeramente señalar que en 1993, cuando se inició el proceso de reforma, teníamos en Colombia un sistema compartimentado, segmentado, en donde la población accedía a los servicios de salud fundamentalmente de acuerdo con su capacidad de pago. Cerca del 15% de la población accedía a los servicios privados con el pago directo o con pólizas de seguros de salud o de medicina prepagada. Alrededor del 20% de la población accedía a los servicios mediante los seguros sociales, tanto seguros sociales para trabajadores privados como para los empleados públicos. Y la población más pobre tenía acceso a servicios de asistencia pública ofrecidos por hospitales públicos y centros de salud, a los cuales lograba acceder un 40% de la población. Es decir, que aún así el 25% de la población no tenía acceso a servicios básicos de salud. Este sistema no solamente era compartimentado, era además inequitativo. El 52% del gasto en salud era gasto privado, es decir, dedicado a ese pequeño porcentaje de altos ingresos y el 48% del gasto en salud era gasto público, que sumaba el gasto en la seguridad social y el gasto en la asistencia pública, en los hospitales públicos. Hay que señalar que además existía insatisfacción por los servicios en cada uno de ellos. En uno, por los costos, los altos costos que impedían realmente el acceso de mucha gente, la falta de protección y de cobertura de servicios, en otros casos por la calidad de los servicios y en otros por la oportunidad de los servicios. El mandato de la Constitución, una nueva Constitución que se hizo, el mandato era construir un sistema unificado bajo los principios de la seguridad social. Y en esa medida ordena la Constitución y luego la ley crear este sistema único con criterios de solidaridad, universalidad y eficiencia. Para procurar la solidaridad, pues se utilizaron todos los elementos fundamentales o los principios de la seguridad social: la obligatoriedad, la uniformidad, en el sentido de que antes había diferentes tasas de cotización, diferentes planes de beneficios, diferentes coberturas, y todo esto se unifica en una misma tasa de cotización, una misma cobertura familiar y un mismo plan obligatorio de salud. Por otra parte, se procura la eficiencia, y dentro de muchos elementos que se apuntaron hacia allá, se incluyó la pluralidad y diversidad de responsables del aseguramiento y de la prestación de servicios de salud y la libre elección por parte de los usuarios. Para alcanzar la universalidad, que es el tema al cual estamos de alguna manera convocados, a partir de la cobertura inicial de la seguridad social, que era del orden del 20%, se inicia una ampliación de la cobertura con la cobertura familiar de este 20% que ya estaba incluido. Eso significó un salto que se acercó al 35% de la población colombiana. Esto implicó, obviamente, un aumento de las contribuciones que se hacían con cargo a la nómina. Las contribuciones inicialmente eran en general para los trabajadores privados del 8% del ingreso base de cotización, o sea, del salario mensual. Pero ese 8% se pagaba en 4% por parte del trabajador y 4% por parte del empleador. Para avanzar hacia la cobertura familiar, se incrementó la cotización y se llevó al 12% inicialmente. Adicional a este incremento de la cobertura, se propuso la afiliación obligatoria de trabajadores independientes con capacidad de pago. No los informales, sino independientes con alguna capacidad de pago, profesionales, personas que tenían contratos de prestación de servicios con el Estado o con algunas entidades, y eso significó otro incremento importante de la cobertura porque además incluía obligatoriamente al núcleo familiar del trabajador independiente. Adicionalmente, se requería incluir a la población de escasos recursos mediante subsidios del Estado. Y ese fue el otro gran proceso que nos permitió avanzar hacia la universalidad. Los subsidios eran pagados con tres fuentes diferentes que se juntaban. Fuentes del gobierno nacional, fuentes de los gobiernos locales, especialmente de los locales, pero a veces también de gobiernos regionales, y algunos recursos de solidaridad del régimen contributivo. Esto que tenemos aquí se denominó el régimen contributivo, los que ya estaban afiliados, sus familias y los independientes. Y esta población de escasos recursos afiliada al sistema se conoció como el régimen subsidiado. Eso permitió que en Colombia se diera un gran salto en la cobertura de la población. Ustedes pueden ver aquí en la parte baja, en azul más claro, la afiliación al régimen subsidiado, es decir, población de escasos recursos que fue progresivamente incorporándose, teniendo los saltos más importantes para el año 96-97, cuando ingresaron los primeros 7 millones de personas subsidiadas. Posteriormente hubo un salto importante para el periodo 2005-2006. Antes había habido un salto aquí hacia el año 2001, donde se llegó a 11 millones de personas, y en el año 2005-2006 se logró alcanzar hasta 18, casi 19 millones de personas, para que en la actualidad tengamos alrededor de 23 millones de personas que reciben subsidio por parte del Estado para garantizar su acceso a la seguridad social. En el azul más oscuro está la afiliación al régimen contributivo, que también tuvo un crecimiento inicial con la afiliación familiar, los independientes, y progresivamente mantuvo más o menos un crecimiento sostenido con el crecimiento del empleo. En un azul más oscuro hay un grupo que se denominan regímenes especiales, que por la ley quedaron por fuera del sistema, que son básicamente los afiliados de las fuerzas militares y de policía, los maestros que prefirieron un sistema propio, y los trabajadores petroleros. El resto, hoy se puede afirmar que en Colombia hay una cobertura universal de salud. Todo colombiano que nace automáticamente recibe la afiliación al Sistema General de Seguridad Social en Salud. Cualquier persona que lo solicite, si por alguna circunstancia no estuviera afiliado, puede obtener su afiliación, e incluso el sistema ha permitido que más de 1 millón de personas migrantes provenientes de la hermana República de Venezuela, por los problemas que se han presentado allá, que llegan a Colombia, se hayan afiliado y se hayan beneficiado del subsidio para pertenecer al sistema de seguridad social en salud de Colombia. Esta cobertura universal no es solamente una cobertura en el papel, tiene unos resultados en salud que de alguna manera se pueden observar aquí con esta gráfica sobre la mortalidad evitable, la evolución de la mortalidad evitable en el siglo XXI. Hacia finales del siglo XX se inicia el proceso de universalización de la cobertura y miremos cómo evoluciona en azul claro en la gráfica, el azul claro es la evolución de Colombia, que antes estaba por, por debajo o por encima, en mortalidad evitable mejor, por encima del promedio de América y que la supera el promedio de América. Colombia bajó en 46% la mortalidad evitable durante hasta el año 2019, comparado con una disminución del 22% del promedio de América. Es muy importante señalar esta cobertura que permitió que Colombia pasara del puesto 20 entre los países de América al puesto 5º en relación con este indicador de mortalidad evitable. Ahora veamos cómo se desarrolló el proceso para focalizar, para identificar a quién subsidiar y a quién subsidiar primero en el sistema de salud. Lo primero que hay que señalar es que SISBEN es una sigla que significa Sistema de Identificación y Selección de Beneficiarios de Programas Sociales. Esto permite al gobierno pues, identificar, clasificar y seleccionar los potenciales beneficiarios de todo tipo de programas sociales, no solamente de salud. Este no es un programa exclusivo del sector salud, no está bajo la responsabilidad del sector salud y sirve para otros propósitos también, educación, vivienda, etc. Sin embargo, el sector salud, al finales de la década de los 90, fue el primero en usar el SISBEN y durante un tiempo largo el único que desarrollaba el SISBEN. Y entonces la población generó una cierta confusión del SISBEN con salud, incluso llegaron a llamar al carné de régimen subsidiado de salud el carné del SISBEN. Pero hay que señalar que son cosas diferentes. El SISBEN simplemente es una herramienta que permite la caracterización socioeconómica, que permite la clasificación en función de esa caracterización socioeconómica y asignar determinados subsidios. Uno de ellos es el caso del sector salud. Ahora, ¿cómo se aplica el SISBEN, la encuesta? La encuesta se desarrolla fundamentalmente en la vivienda. No hay encuestas en la oficina del gobierno. No es posible que la gente vaya y le hagan unas preguntas y le hagan la clasificación socioeconómica. Tampoco es posible una encuesta telefónica. Tampoco es posible que se encueste aleatoriamente la población en las calles. Se requiere que se haga en la vivienda donde vive la familia que está siendo evaluada, el hogar que está siendo evaluado. En ocasiones, algunas formas de fraude para este proceso implicó que algunas personas pretendieran que se evaluara en una vivienda diferente a la propia o a la donde realmente viven. Y obviamente eso implicaba todos los controles y toda la vigilancia por parte de los diferentes responsables del CISBEN. Ahora bien, el CISBEN se aplica o se ha aplicado de dos maneras diferentes. Una aplicación masiva, es decir, cuando salió por primera vez el CISBEN, se hizo una aplicación extendida en todos los municipios de Colombia, en cada uno de esos municipios, en todas las viviendas, especialmente de los barrios y de las veredas de más bajos recursos. Esa aplicación masiva era financiada por el gobierno nacional y se aplicaba, como es obvio, en el ámbito local. También existe una aplicación ad hoc, puntual, por demanda, cuando alguna persona cambia de domicilio de una ciudad o de un municipio a otro, o cambia de vivienda, podría requerir entonces la aplicación de este instrumento y a solicitud obtenía la visita nuevamente en el nuevo domicilio para recibir esta encuesta. Lo importante a señalar es que la encuesta se debe desarrollar en la vivienda porque especialmente al comienzo, en la primera versión del CISBEN, había un gran énfasis en las características físicas de la vivienda, desde los materiales, el tamaño, el acceso a los servicios públicos, que era necesario ser verificado in situ por el encuestador. Y así evolucionó progresivamente a través de los años las diferentes versiones del CISBEN. Hemos tenido 4 versiones del CISBEN. El CISBEN 1, que fue la aproximación inicial y que permitió la afiliación de cerca de 11 millones de personas al sistema de salud y alrededor de 15 millones fueron censadas. Estaba centrado especialmente en las características físicas de la vivienda, el acceso a los servicios públicos y una inferencia sobre los ingresos que se determinaba sobre la tenencia, sobre la posesión de algunos bienes dentro de la vivienda. Posteriormente se involucraron, en el año 2005 se produce la versión 2 del CISBEN, en el año 2011 la versión 3 y en el año 2021 la versión 4. Progresivamente se han ido incorporando elementos como el grado educativo, tanto el grado educativo de los padres, porque eso permite no solamente identificar las condiciones de pobreza que han vivido, sino también la capacidad de generación de ingresos que pueden tener en su momento. El grado de escolaridad de los niños también permite evaluar el nivel de rezago que pudieran tener en función de la edad. Progresivamente ha habido desarrollos tecnológicos que progresivamente han ido mejorando el proceso y finalmente se ha llegado a incluir algunas preguntas sobre los ingresos y gastos en el hogar, porque al principio, cuando el énfasis era en las condiciones de la vivienda, algunas personas se quejaban de que, por ejemplo, algunas personas de edad podían tener una vivienda más o menos aceptable, pero ya no tener ingresos. Y eso generaba unas distorsiones y unas inconformidades, y entonces progresivamente se fue incluyendo elementos que pudieran medir más claramente el nivel de ingresos y de gastos de las familias. El CISBEN 4 ha fortalecido este criterio, orientándolo además a la capacidad de generación de ingresos de esas familias. Ha permitido también cruzar información con otras entidades gubernamentales para confirmar los resultados de la encuesta. Muchas veces la gente puede afirmar que no tiene ingresos, pero por otro lado está pagando impuestos o haciendo negocios que se pueden verificar y confirmar en otras fuentes de información disponibles para el gobierno. Ahora se ha permitido con el nuevo CISBEN tener un grupo o grupos segmentados, una mayor segmentación de los grupos del CISBEN. Al comienzo existían 3 niveles del CISBEN y quienes estaban por encima de él. CISBEN 1, CISBEN 2 y CISBEN 3 significaban el CISBEN 1 la población más pobre, el nivel 2 un poco mejor, pero aún pobre, y el nivel 3 eran personas que estaban un poco ya en la mitad del escenario económico. El sistema de salud aprobó inicialmente afiliar o que tenían derecho a ser afiliados al régimen subsidiado de salud la población que estuviera clasificada en nivel 1 o nivel 2 del CISBEN. Más adelante, hacia el año 2005, se introdujo la posibilidad de subsidios parciales para la población del nivel 3 del CISBEN. El subsidio parcial no fue no consistía en aportar una parte del gobierno y esperar un aporte de la familia, porque el recaudo se vuelve muy difícil de efectuar. Simplemente el subsidio parcial consistió en que un paquete de servicios de mediana y alta complejidad fue subsidiado íntegramente, pero las personas debían pagar la atención en el primer nivel o en la baja complejidad. Ese fue el modelo de subsidio parcial que finalmente terminó en que todos los niveles 1, 2 y 3 fueran subsidiados. Ahora, ¿qué problemas se identificaron en esto? El CISBEN es una aproximación a una caracterización socioeconómica. Sí.
Dr. Eduardo? Sorry, we're having time constraints. Kindly, if you're able to conclude it, I will appreciate it.
Ok. Finalmente, quisiera señalar que los retos que se han utilizado, que se han de tener en cuenta es que esto tiene un costo importante, requiere unos recursos financieros que no pueden ser pagados en el ámbito local. Es muy difícil que los municipios tengan la capacidad para hacer. Al menos en Colombia se requirió de un financiamiento del gobierno nacional. Sin embargo, la operación y la logística debe ser manejada en el ámbito local, obviamente con capacitación, entrenamiento y supervisión por el gobierno nacional. En la actualidad se está utilizando mejor tecnología En el año 95 utilizábamos lápiz y papel. Hoy se utilizan dispositivos de captura electrónica, como tablets, etcétera. Y obviamente hay que mantener el interés en evitar el fraude, prevenir el fraude que puede ocurrir y que intentó ocurrir en varias ocasiones en el caso colombiano. Eso es básicamente lo que quería señalar y si hay alguna pregunta, con el mayor gusto. Muchísimas gracias.
Thank you very much. We've had a lot of discussions today in regards to proxy means testing, from what is proxy means testing, what it's used for. And thank you, Dr. Eduardo, for giving us a more in-depth discussion, especially the fact that it's for social programs and it's not limited to health. Maybe my first question would be to my colleague from KNBTS. Is our proxy means testing limited to health? Pius,
Could you please come again?
is our proxy means testing tool limited to utilization in health?
No. Actually, when Faro was presenting, he mentioned the issue. He mentioned that issue of the social protection who are in charge of the enhanced single registry, and they also use the same tool, PMT. So in health financing, it's basically to try to determine the ability to pay for a certain household.
In terms of health, in terms of education, not just in terms of accessing health alone.
No, in the context of health and social protection, in terms of education, I'm not aware.
Okay, thank you very much. My next question would be to Shana. Shana, it's really not a question because of time, but I think you've had a lot of the discussions. You're from the International Labour Organization, in essence, linked to our social protection. You've had the experiences in Kenya, Philippines, and Colombia. What's your take-home message for today? For us?
Well, I think it's good to learn from other countries, and I'm really happy to see that the country colleagues were able to present. I think the main take-home message for me is to really think about, where you want to go with a policy and design it accordingly, and in accordance with the other things that are already in existence in the country. So really thinking about universality and learning from the countries like Colombia and the Philippines on how where they've made progress and also where they have had issues on the way. I think that's the main thing.
Sorry, I had a technical hitch. I don't know if you finished, Shana.
Yes, that's okay. Thank you.
Okay, thank you very much. Our colleague from Philippines, Dr. Lemuel, thank you for the oversight in Philippines. I would like to know more about the informal sector. Are you having challenges and what mitigations you're having in form of contribution? Because we both have subsidization, we have contribution, and what we would like to learn mostly in Kenya is how do you tackle the issue of contribution? I saw that your scope is not limited to Philippines only within the country, it's also outside the country. I'm wondering if they can be able to use the insurance in the other countries as well. So kindly see if you can answer that. Thank you.
Yeah, thank you for the question. I think globally, when you're implementing a social health insurance program, the challenge is really on the self-employed, the informal economy. It's really hard to get exactly how their capacity to pay the premium. So that is a challenge in the Philippines of having those Filipinos practicing their profession and even engage in their own business to contribute. That's the reason I think that um, um, we rely on their declaration of income. So there would be some problem, and because in the Philippine model, there's an income floor and an income ceiling. So most likely, most of those engaged in the informal economy, they would be declaring their income based on the income floor, which is 10,000 a month, which is really, so I think that's still our challenge here in the Philippines. Our focus is really on the poor. We have to ensure that the poor and the vulnerable groups are covered, and if they need health services and feel health, the health insurance is there to support their healthcare costs. So recognizing that there's always limited in budget funds, so really have to focus. That's the reason why current discussion in the Philippines in line with the current ongoing amendment is that for those in the indirect contributors in the Philippines, who are the poor and the vulnerable groups, the senior citizens, the elderly, persons with disability, government should pay for their healthcare costs through the subsidy. And that is the challenge, that whatever benefits or healthcare costs for this vulnerable should be paid by the national government through, as I mentioned earlier, through sin taxes. So it is really a challenge still for the Philippines to let those in the informal economy, those who have the capacity to pay premium, to contribute. This is vis-a-vis to the mandate that all Filipinos are now under the program, the National Health Insurance Program. And then when they need to be the healthcare cost is fully covered by the corporation. And right now, I think we still have that elbow room on the finance to finance the healthcare costs of those Filipinos, even in the informal. And I think the one consideration is really not on the as I have mentioned during the global symposium, it's really who are your providers. If your providers are government, so the cost of care is in a way manageable or controllable. So the model in Kenya, you should have to first to identify who are your providers, if this mostly public or private, because in the Philippines it's roughly 55-45 ratio with more private beds. So you have to consider that scenario. And the other one, I think, is really what benefits should be paid. If you would go into health insurance, you should identify what benefits the program should be paid, and it should be clear to the citizenry that the government would only, through the social health insurance, would only pay for so much and support so much on the healthcare cost. Okay, thank you.
Thank you. Thank you for those insights. I think they go a long way, and they're quite insightful. And with us, we're listening. So many people are listening in, and we have a lot of key takeaways. Dr. Eduardo, apologies for our language barrier. I hope you'll be able to hear out my question. I love CISPEN. That approach, I think it's one of my biggest takeaway home as the system for eligible beneficiaries. How can you advise us? Because the biggest challenge in Kenya is the decentralization in systems. We have gaps in communicating across all sectors. So from your experience, because you've done 1, 2, 3, 4, how do you think, how would you advise us to go about it?
El micro está en silencio.
Ok, gracias por la pregunta. Quisiera señalar, pues, como ya es conocido por todos, no hay una vía única, ni siquiera una llegada única a un objetivo. Esto es una búsqueda permanente, pero sí quiero señalar que la vía de crecer la cobertura de la seguridad social es una vía bastante justa. Es lo que uno quisiera para uno mismo en su país, que no quisiera perder en su país, y por eso mismo es lo que en justicia uno debería propiciar para todos, incluso para las personas de más escasos recursos. De tal manera que yo creo que esa búsqueda que tiene hoy Kenia de incrementar la cobertura de salud por la vía de la seguridad social es plausible. Ahora bien, hay dificultades, sobre todo a la hora de, una vez clasificada la población, pretender obtener un pago. El régimen contributivo en Colombia funciona porque hay una retención en la fuente, una retención del pago del salario. Al momento del pago del salario hay una retención que va al fondo de salud, a la administradora de este fondo. Eso es muy difícil que las personas vayan voluntariamente, si no se retiene obligatoriamente eso, para que vayan voluntariamente y periódicamente a hacer esos aportes, generalmente es muy difícil. Y ocurre que solamente acuden las personas que se enferman. Esas personas sí acuden regularmente a hacer sus aportes, con lo cual se genera una distorsión, una selección adversa en donde la afiliación, la protección no sería para todos, sino solamente para los enfermos, lo que genera una distorsión en el sistema. Entonces, buscar mecanismos que simplifiquen y eviten ese recaudo tan difícil. Esa sería una recomendación importante. Yo creo que ya he mencionado en la presentación también el apoyo del gobierno nacional para la aplicación del testing es importante, y el desempeño local en ese campo.
Thank you. Thank you very much.
Gracias.
I like how you pointed out the adverse selection, because that challenge is real and we feel it a lot here in Kenya. So without much further ado, I'm very sorry for keeping everybody more than the intended time. But we've learned a lot. We've learned a lot from the International Labour Organization. We've learned a lot from Philippines. We've learned a lot from our colleague from Colombia as well, and also from Kenya. It's either
Okay, thank you very much. And thank you very much to everybody for your contribution. Next week, we are finalizing this series of webinar sessions, and we will be talking about on the institutionalization on health technology assessments as a way to create evidence-based decision-making for designing and updating benefits package under the Social Health Authority or Social Health Insurance in that case. Thank you.
Thank you. See you next week, and I hope you've enjoyed the session. Please, you can find it uploaded in KNH Research, and if you have any input, please reach out. Kwaherini. Bye-bye. Thank you to all our guests. We appreciate your time.
Everybody.
Thank you.
Thank you. Bye-bye.
Thank you for the opportunity. Good night.